Hi, everybody. Dr. Fiona Lovely here of Not Your Mother's Menopause podcast. And I have the great pleasure today of talking to Dr. Teresa Irwin, who is a urogynecologist, but she calls herself the vaginacologist. And she has kind of a cool story about how that name came about. But you don't want to hear from me anymore. Let's turn it over to Dr. Terry. Dr. Terry, tell me about you, please.
Well, so as you mentioned, I am a urogynecologist, and our medical board decided to come up with a simpler term. So they decided to change urogynecology to female pelvic medicine and reconstructive surgery. What does that mean, right?
Totally.
So I thought, no one knows what that means, and I took the hint from, or I should say, I stole the name from my son when he was in high school. One of his buddies came up to him and said, "Hey, dude, what is it that your mom does for a living?" He's 15, 16 years old, and he hears me talking about vaginas all day. So he said, "Vaginacologist." So when he told me the story, I said, "Of course, this is exactly what I do. It's perfect. I treat problems of the vagina, problems that not a lot of us really want to talk about. So bladder problems, leaking bladders, leaking bowels, problems with sexual function, and sagging vaginas."
Oh boy, you have stepped in it there, sister. So tell me what it means to be a pelvic reconstruction surgeon.
Well, so we treat those problems. So what they are officially, for example, would be urinary incontinence. So basically the uncontrollable loss of urine, which can happen whether you're exerting yourself, anything such as walking, running, jumping, laughing, lifting, exercising, sex, or leaking when you get that sudden urge that you can't make it to the bathroom in time, gotta go. And other ways. Those are just the most common types of urinary incontinence. Urinary incontinence is actually such a common problem that so either you or me, or maybe both of us, is going to have urinary incontinence at some point in our life. More than 50% of women will have bladder leakage. The other conditions that I treat are bowel leakage. So uncontrollable leakage of stool, whether it's liquid or solid. And also things like constipation. So I treat kind of opposites. So bladder leakage, but also inability to pee adequately, or bowel leakage, poop leakage, and constipation, as well as what I call, sort of what I've termed as a sagging vagina is basically prolapse. So prolapse means that the pelvic organs are starting to descend in the vagina. This here is the bladder. And then I took the uterus out. I did a hysterectomy on Tina, but it used to be right here. And then you've got the rectum over here. So if you look, there's not much space. The tissue layers are super close. And right below, so if I take the bladder out, then you see this. So this here, so you can see this way. So there's the vagina. When I took the bladder out, do you see the other hole in front? So there's not much space. So whenever there's a sagging vagina or weak tissue, then the bladder starts to push into the vaginal wall, and we call that bladder prolapse or cystocele. When the rectum starts to do that, we call it a rectocele. And if she has a uterus, when the uterus starts to drop low within the vaginal canal, we call that uterine prolapse, or if the uterus is out, then it's vaginal cuff prolapse. So cuff is the top of the vagina where the uterus used to be. And in many times women don't know it's happening because, when it's early on, when it's starting to descend, remember the vagina is hidden. Many people often refer to the vagina as down there, but that's the outside's the vulva. And so really the vagina is the tube inside. So when things are starting to descend within the vaginal canal, you may not see it initially or feel it sometimes, many times I should say, until it's really low. And at that point, it's pretty severe. So that's not in a nutshell, but in a nutshell, that's what I do.
So
So
what are you repairing there? Is it a pelvic floor muscular thing? Is it more of a, do you lift the bladder? How does that work?
when it comes to how I repair it surgically, it depends on what's going on. So there's anatomy and there's function. The anatomy being the sagging or the prolapse, right? The descent of the pelvic organs being the bladder, the rectum, and the uterus or top of the vagina. That is an anatomy problem. So yeah, I basically restore to what the normal anatomy should be. If it's function, in other words, they're incontinent or they can't pee, or or the other way around with the rectum, they are constipated or they're having stool leakage, then I'm going to repair the function of it. So it depends on what's going on. Many times it's a lot of things that I'm doing. So for example, yesterday I had a patient who had prolapse of the uterus, of the rectum, into the vagina, and the bladder, as well as stress incontinence, which is leakage when you exert yourself, what I mentioned earlier. And she had urge incontinence. So she gets an urge and she's not going to make it to the bathroom in time. So I did 7 procedures on her.
Wow.
To repair all of that. So, did a hysterectomy. Because of her age, she chose to have her ovaries removed, which we can talk about that, because that's a huge
big one
to talk about, whether
Yes.
you have your ovaries removed or not. And I'm not a big proponent of doing that, but we'll talk later. So then I in her case, she had some scar tissue. I had to take that down. And then I did some of the prolapse repair from the robotic or the abdominal route. So basically lifting everything up. And then I went to the vaginal portion and I did a sling. So that is considered the gold standard treatment for stress incontinence. And then I also did a rectocele repair. So that's kind of like doing an abdominoplasty, but of the vagina. Mm-hmm. As well as I fixed the perineum being the area between the vagina and the rectum, because the muscles many times, just like in pregnancy, women's rectus muscles pull apart, they get pulled apart, and many times they come back together. But in the perineum, the same thing happens, but it's much more difficult for those muscles to come back together because we're constantly standing on our pelvis, not standing on it, but you know what I mean. We're putting pressure on it by standing or doing anything that we do day to day. So a lot of times the muscles get pulled apart, and that causes a wider vaginal opening and can increase the risk of other prolapses. So I fixed that. And then I also put a nerve stimulator for her urge incontinence, because that doesn't go away with the sling. It goes away with initially behavioral changes and medications, but if that fails, then you put in a nerve stimulator if they're a candidate.
Just out of curiosity, nerve stimulator, would that be the pelvic splanchnic nerve you're targeting?
It's actually, I like this little saying that we have, and that's we're going to try to wake up the nerves of S2, 3, and 4 to keep
poo off the floor.
Poop off the floor.
Yes, I knew that was coming.
Yay, you knew it.
I did. I'm pretty sure a lot of those medical terminologies, those analogies that we learned in med school will be written on my gravestone because they're so in my brain.
Well, especially that one, because that one's memorable.
S2, 3, 4 keeps poo off the floor. Yes, that's how I learned it. So
basically, I put a lead into the woman's back, through her back, and it goes to the foramen of the spinal cord. So it doesn't actually go into the spinal cord, but the nerves come out laterally, right?
Yep.
And that lead has 4 electrodes, and I put it into S2, 3, 4. Primarily S3 is the goal. And we test during surgery for certain things. For example, we want her big toe to move, and we want her to do what's called bellowing. So the perineum starts to lift. It does this. And you tap on the little electrode, and it goes, woo, woo.
Okay.
And the toe goes, woo, woo.
Then you're like, you got this.
That's how you know you're in the right place. So so during that time frame, she wears the lead for 2 weeks, and she'll have a little smartphone that she can program, and she'll change the programs or amplitude according to her symptoms. And the goal is that she has at least 50% improvement in urge incontinence. It's also used for stool incontinence. It's actually an excellent device for stool incontinence. It's more successful in that than other things, which is wild because, I mean, there are some cases where they'll have a sphincter tear and the nerve stimulator helps much more than repairing the sphincter. Interesting,
Wow.
huh?
Yeah.
Yeah.
Yes,
So she has
absolutely.
more than 50% improvement. Then we come back 2 weeks later and then put a battery, kind of like a little pacemaker, but for the bladder or the valve, and attach it to the lead. So that's how that
Wow.
works.
So this surgery, as you've described it, which by the way, fascinating. Thank you for the little master class. I love it. This is sort of uh, the end result of many years of symptoms. And from what I understand from talking to you, is that you really want to try to get the information to help women at a much younger age than, let's say, the
Absolutely.
patient you worked with yesterday. So
Yes,
talk to me a little
definitely.
bit about that, please.
Yes, yes, absolutely. This is what I am super passionate about because initially, I went through residency and became more subspecialized. And my big thing was, ooh, I want to learn all these surgeries. I want to do them, in a way that's going to treat all these problems, and that's going to be the end all. They're going to be fixed, right? And the problem is, and this is the analogy I use. If someone goes to have bariatric surgery and they lose 100 pounds, right? Then they go back to their old behaviors. They eat all the high carbs, they don't exercise. What's going to happen? They're going to probably gain the weight back. Well, it's not quite to that severe degree, but it's pretty close. So if I go and I spend 4 hours and I fix a woman's bladder incontinence, bowel incontinence, or prolapse, etc., but then she doesn't do, and we'll talk about some of those, the behavioral changes, doesn't keep up with the exercises, doesn't avoid the bladder irritants or the things that make her constipated, well, her likelihood that things are going to recur is going to be higher than if she followed all of that. So the basics, kind of like everything, right? The basics are so critical. Diet and exercise, diet and exercise. But the thing is, most people don't know what that really is, especially when we talk about the pelvic floor. Why am I going to be on a diet and exercise
Mhm.
regimen for my pelvis? Huh? Are you crazy? So my goal is to provide early education so that they can prevent these problems later on in life. But here's the problem. You don't have a problem, right? My pelvis is fine. I'm not peeing or pooping on myself. Why do I need to do anything? And that's going to be my biggest obstacle. And I want to target, especially the young, because there are certain activities that they're doing now. For example, women that are volleyball players, they're out of all of the athletics, they are the ones that have the greatest risk of developing stress incontinence, 116% increase over other athletic sports. So it's not to say you don't play volleyball. It's to say, okay, this is what you can do so that you reduce your risk of that coming about later on in life. So it is early education at an early age. Now, don't get me wrong, any age it's never too late. And I say that because every day I do have women that have milder degrees of issues, and when I send them to the pelvic floor therapist, they're like, why didn't anybody teach me? I am so much better. I don't need surgery. And I'm like, great. That's really great. So that is what I want to do. So, my patients do so much better if they go to the therapist. And in the past, I didn't require that they go. I just told them they had to. And because through time I found, and also in research, that patients do much better if they have done that and continue to do it post-surgery, that they do way, way better. So I decided that I will not operate on anybody that's not gone to the pelvic floor therapist. And now, since they stole my thunder by making my surgery
You
numbers so
good.
much better, then I decided to steal their thunder. Now I'm educating people with what they do.
Now you're the vaginacologist. Which is really this desire in you to get the information out to the women at a time before they become symptomatic
Mm-hmm.
is
Yeah.
really what drove you
Yeah.
to create this social media presence that is a fairly new thing for you, but is become quite popular. So tell us about that, please.
Yes. So, yeah, again, my goal being to get the education out to many because I mean, what did we have before the internet in terms of education?
Encyclopedias and libraries.
Or, Playboy, Inquirer,
Right.
really good sources,
Ugh,
right?
yuck.
So, so it was terrible. That's kind of where it started, where I was trying to educate myself. I was trying to gain control of me. And now that we do have these sources, it's still not out there. And again, when you don't see that as a problem, you're not going to really pay attention. So when I embarked upon making it my priority to get the information out, I discovered that I actually have to use social media to make an impact. Because if I don't, that's the new wave. I mean, I keep up with medical, surgical skills and all the latest and greatest, but I hadn't when it came to education for the masses versus just in my office. So I went to my social media gurus, which are the young ones. So my son, his girlfriend, my goddaughter, and my pre-med student, I hired them to help me because up until late February, basically I was not on social media at all, very little. And I avoided it like the plague, but that was absolutely the wrong approach. And I did it because, you often hear negative things about, they saw this on your Facebook and, now, some negative thing came up. And because I'm also an expert witness, that even pushed me more to treat it like it was the plague.
Mm-hmm.
But I was looking at it from a completely wrong aspect. So now that I know that I can actually take advantage of the benefits that it can have and provide correct, proper early education, that's when I embarked upon it. And I started with TikTok because that's where mostly, although that's changing, mostly young women are going to be watching. So it's really great.
Wow.
It's a lot of work, and obviously I'm not getting paid, but that's okay because I know it's going to make a difference. I just need to get it out to more. So
Well, and I
that's
think
what I'm doing.
I get where you're going. Part of the problem is that especially for our generation, we were raised by women who we did not talk about pelvic things. We didn't talk about orgasms. We didn't
No.
talk about the actually what happens during labor and delivery. We didn't
Mm-hmm.
talk about the changes of a woman's body before, during, and after pregnancy. We certainly didn't talk about when grandma sneezed and leaked.
Yeah.
So nobody wants to talk about that. So
Yeah.
here we are, 2020, and I still have patients who don't want to discuss this with me. I have to bring it
No.
out in them. And that's vaginal dryness, painful intercourse, of course, those
Mm-hmm.
ones, and the urinary incontinence. That's one we don't want to talk about. It's funny, a few years back, I was asked to do a women's, it was a hormone summit. And it was by a woman in a very conservative area of the world. And she wanted me to speak on the taboo subjects of menopause, which we had started to cover. And of course, that's it's all the stuff I just talked about. So, and
Yeah.
more, right? And
Yeah.
as soon as I started to talk about it, we met like this. As soon as I started to talk about it, I could tell she got really uncomfortable that I was talking
Mhm.
about what I was talking about. And I'm going, sister, like, this is the taboo of menopause. What did you think
Yeah.
I was going to
That's what you
talk?
asked me to talk about.
Oh, right. You thought it was, I just got bitchy with my boss, and that's the taboo of menopause. Oh, no, sister.
Yeah.
And I think it's going to take people like you and I who aren't afraid to say the words
Hmm.
vagina, vulva,
Yeah.
rectum, anus, all of those
Right.
things. We need to talk about it. So
It really
good for you for saying, I want to get this information out. And it's just like the podcast. We don't get paid to do it. I do it out
Mhm.
of a love for it because I know, or I hope that it's going to bring information to somebody who either can't access information
Mhm.
where they are, or, maybe something they wouldn't even think about. Break it down for us. What are the things we can do for our pelvic health right now?
Well, there's a lot of things actually, but I'll give you some of the basics.
Please.
So, uh, many times the way that we've been taught, everyone has heard of Kegel exercises, right? but most people don't do it correctly. And I tell my patients this because I tell them, I want you to go see a pelvic floor therapist.
Mhm.
She's going to teach you how to properly do the pelvic floor exercises, or what we know as Kegels. And almost 9 out of 10 times they're like, I've been doing those all my life and that's not helping. And I said, okay, well, listen, I will be the first to admit that I did not do them correctly until I really delved into my subspecialty. So I want you just to go visit with her. She's going to teach you a bunch of other things that you didn't realize are also exacerbating your problems. So when I tell them that, when I say, yeah, me too, they're more willing to do it. So the way that you do it is not by, a lot of women will say, well, I just pretend like I'm holding my pee, and I do it when I'm peeing. Like they'll try to hold it in the midstream. That's actually the worst place to do it,
Mhm.
because you're going to cause this voiding dysfunction, voiding meaning peeing, and dysfunction, of course, means not functioning properly. So you end up training your bladder to do this intermittent stop-start that is not good, because then you have a harder time emptying well. So the most important exercise that is a pelvic floor muscle exercise or a Kegel is to pretend like you're holding your poop, not your pee. And you want to do what it does, it strengthens slow twitch muscles. So I like to give the analogy of pretending like you're on an elevator and you're going to go to the 10th floor. So you start on the first floor and you squeeze just a little bit, just very little. You go to the second floor, squeeze a little bit more, third floor, a little bit more, until you get to the 10th floor. That's the max that you can squeeze your anal sphincter. And then you hold it as long as you can. Ideally, if you can do 10 seconds, that's wonderful. And then slowly for 5 seconds, so you take half the time to unsqueeze or go down the elevator. And repeat it as many times as you can, ideally 10. Most of the time, women can't do that, the full amount that I suggest, but it doesn't matter. Just start with something and do it every single day. So it is it's something that really, 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 really is super important. And we don't realize how important it is. It's, it's like lifting weights. You're exercising, you're toning your body. You don't do it, it gets flaccid. So that's what happens in the vagina. You don't want a flaccid vagina. So do your exercises. So those are Kegel exercises, and that's just one of lots more that you can do.
Okay, so here's what I want to do to wrap up. Please tell my listeners where they can find out about you, about your awesome social feeds, please.
Great. Well, I'm on pretty much all of them, except for Twitter. So TikTok, YouTube, Instagram, Facebook. YouTube, not a lot yet, but we're getting there. And lots of videos on the things that we've talked about. The best place probably to start out with is on our website, because we have, for example, the pee position PDF that shows you pictures and describes how to pee properly. You find it on our website, which is www.thevaginacologist.com. And all my social media handles are going to be either Dr. Teresa Irwin or the Vaginacologist. So either way. And also, we're going to be launching a masterclass that's going to dive even deeper on the things that you can do to preserve your vagina. The anti-aging secrets further discussed without having to spend money on your vagina. It's free. I'm talking about the things that I'll teach you, not the classes themselves. And if you want to do that, then it's going to start in September, and you can go on through the website for that. So, because we've only touched the tip of the iceberg on lots of things, on what you can do. So, just like what you teach, I mean, can you talk about it quickly?
Oh.
So much, right?
Well, it's you know what? Here's the thing. I'm excited about this master class that you're talking about, because this is the information really women really want to know. And I can see you're a bit like me in that you have this sort of multi-passionate brain. There's all these things you want to talk about, but I think from sometimes the marketing people say what we need to do is drill it down to one thing. And
Yeah.
my favorite thing to talk about is the spiritual passage of perimenopause. And of course, as you know, the spirit and the body work together. So if a woman comes to me with all of these sort of physical symptoms, we can link it back to the psychological response and that
Oh,
spirit.
yeah.
Understand that that's what I mean when I say spirit. I know
Sure.
you're not so concerned about that. I was at a party recently and I had somebody ask me about what I did, and she was very sort of interested in my podcast, and I said, I'm writing a book and all these things, and my
Oh,
jam,
cool.
my juice is,
Let me know when you're
will do,
published.
will do. Yes, thank you. Is to talk about the spiritual passage of menopause, and she thought I was talking about church.
Oh no, yeah.
And I'm going, no, no, no.
That's a common misconception. Yeah.
Yes. And so like, no, 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 no. I'm not talking about that. Menopause, I think Dr. Northrup says it best, Dr. Christian Northrup. She says menopause is it's the second coming. It's when we get to birth ourselves.
Ooh.
And there's such a
Oh.
transition in that nobody's really talking about. And I
No.
suppose that's the taboo.
No.
Anyways, this went on
Very cool.
than we thought it was going to, but no surprise. Okay, thank you very much, Dr. Teresa Irwin, the vaginacologist, for spending time with us today. And hopefully we'll talk again soon.
Thank you, Dr. Lovely. It was lovely talking to you. I love your name. Actually, the boys, Keith especially, he's like, I love her name. I said she suits her name. She
Thank
fits
you.
her name for sure. So.
Thank you. Thank you. Okay, thanks again for speaking with us.
Adios.
Bye.